So this presentation for week 8 is Pediatric Endocrine and Common Genetic Disorders. The topics that we'll discuss that you can look up in your book is congenital hypothyroidism, growth hormone disorders, diabetes type 1 and 2, PKUs, and chromosome disorders. So please have your books available as you listen to this, and then please read these sections in your book because there will be test questions just taken from some of the information. It's short, but it's in your book. So your outcomes are listed here. Most of them are, to be able to identify the manifestations and the etiologies and the nursing care and the risk factors for each of the diseases that we're talking about. Congenital hypothyroidism is a child that is born with an underactive or sometimes even absent thyroid. It's pretty serious because, your thyroid is what controls your metabolism. In the olden days, they would just call it creatism. And actually that means, and pardon the language, but it means a retarded imbecile. And that's what they thought of these children that had congenital hypothyroidism. More into the that was way back in time. So probably in the late 50s, early 60s, they have found that by doing a blood test at birth, they could prevent the severe mental retardation of these children. So the babies were given a blood test. The baby has to be 24 hours old, and it will show if he has hypothyroidism. It is actually not very common, but it does happen. And if it's detected early and the baby can be put on medication and get treatment right away, generally these children will grow up and no one will know that that's what their diagnosis was. So the risk factors include the babies being girls and being either extremes, like very low birth weight or very high birth weight. The other really common risk factor that almost all babies have is that the mother of the baby had low iodine levels in pregnancy. Some people will stop taking their thyroid medication. Some people never knew they needed it because, the hormones change when one's pregnant. And some people just are like at the borderline of normal but considered low. For these children, they do a thyroid laboratory test, and it's actually part of a state mandatory newborn screening. If they suspect for some reason that the child has hypothyroidism, they are going to do it before 24 hours. However, before 24 hours, it's not very accurate, and it may come back positive, and then the child will have to have it retaken. And they use the blood spot analysis at 2 days old. I don't know if you learned about that in OB or not, but it's just one of those little sheets that has a circle on it, and you just puncture the baby's heel and drip the blood so that it completely fills the circle. More recently, they have found that a lot of these kids have high lipid levels. So they'll do a blood lipid level. They'll do an ultrasound to see if the child has a thyroid or if it's missing or if it's small or if there's tumors on it. And then also x-rays for bone age, which is usually done a little bit older. The babies usually present with jaundice, very yellow skin color. They'll have a hoarse cry. They're not eating well, although many of them look kind of chunky. They'll have a protruding thick tongue that sticks out. They'll be very lethargic looking. They sleep all the time. Some of them will develop some respiratory problems. To look at them, they may have a short, thick neck, and most of them have some hypotonia. So the newborn baby is born after 24 hours, going into 48 hours, the blood work can be done. They may have gone home and you may be in the outpatient world and you need to see this baby. And it's very simple. You'll do the vital signs and pay special attention to the respiratory status of the baby and the weight. You'll instruct the families that you have to monitor thyroid levels on a regular basis. The babies will be started on levothyroxine, and there is one that's liquid, but it isn't absorbed very well in the system, so it's never really used. So the baby actually will get a pill, a tablet that has to be crushed or non-formularied, so that it's crushed and the baby gets the exact dose they need. Vitamin D promotes bone growth, and people that are on levothyroxine or Synthroid tend to lose some bone tissue. If you're older, osteoporosis might set in early, multiple fractures. If it's a baby, they will need the vitamin D to promote their bone growth and hopefully to prevent some fractures. And the parents need to be educated on giving the medications at the same time every day, an hour before the baby eats or 2 hours after he eats, how to give the medications, and if they're going to give it at all with the formula, it can only be the milk or the dairy-based formula like Similac or Enfamil. It cannot be a soy formula because soy actually will prevent the medications from being absorbed. And the family needs to know the side effects of the medication, and they need to go regularly for their lab work and see the endocrinologist. So next we have hypopituitarism, or one of the diseases with hypopituitarism is growth hormone deficiencies. And it occurs when the pituitary gland doesn't produce enough growth hormone or somatropin. There's several different hormones that function together to work with growth hormones to help the metabolic processes. And every now and then it's one of those hormones that's causing the issue, and those are a little bit easier to fix. And as I said, this is a defect of the pituitary. So a child with growth hormone will present with delayed growth of less than 2 inches, 3 to 4 centimeters per year. So he's slowly not growing taller as all the other kids are, I guess you could say. These kids will have a decline on the growth chart of their height, and we'll start noticing a lot of abdominal fat, and the child will look fat, like their weight will be fine, but their height will be short, which gives them that chubby appearance. Kids with growth hormone deficiencies really get their teeth much later. They don't start puberty till much later, and they have very little actual muscle mass. The boys will have higher voices, and they actually appear to be younger than they are, and they're usually treated younger. So here's a picture that I had of a set of twins, and of course you can tell the one boy is much shorter. He's got a little bit more abdominal fat than the other one, who looks tall and lanky. And the one child, which is on the left, looks pretty immature, nothing like his sister, who looks like a normal 5-year-old child. So the risk factors for a child with growth hormone defects is they could possibly have a tumor in their hypothalamus or the pituitary. So they generally, will do some scans for that. They could have had a head trauma, sometimes even during birth, but a lot of times it's after. They could have had a central nervous system infection. The child could have been on chemotherapy or radiation, or had some type of surgery in the brain that actually has caused the deficiency of the growth hormone. So the tests are done are the insulin and the IGF. Usually the IGF is done the most often. And but sometimes they'll do an insulin stimulation also, because they want to see if it has any effect on the growth hormone. So the growth hormone stimulation test is usually done in a clinic or as an outpatient, and the child needs to be NPO for 10 to 12 hours, and they want them to kind of lay around and not do anything, limited activity. They will put generally like a hep lock in them, and they'll draw a baseline blood draw early in the morning, because growth hormone is secreted in little spurts during the 24-hour period, but it's not constant. So they can't actually, they know early in the morning it should have just been spurted. That's what literature tells us. So they'll draw the baseline blood then. They'll give the growth hormone, and then they'll draw blood every 30 minutes for about 3 hours to see if the growth hormone itself stimulates the pituitary to function. Other tests that will be done, if someone is complaining before you do the stimulation test, something that's so invasive, is a skeletal X-ray, and they'll do just total bone studies for kids under 3 years old. But a 4-year-old and above, they really just need to X-ray their hands and wrists to see how the epithelial plate is doing, and to see if it's up to the age that it should be. Other tests are listed here that they'll do looking for skeletal problems or tumors. After the diagnosis is made, the child will be started on growth hormone injections. And what they expect in the first year is an average of 2 inches. So they expect these children to grow about 2 inches, which is pretty common for a while in the first year or two, and then to grow steadily and not stop growing. They will not be taller than their body chemistry will allow them to be, but they should be as tall as their body chemistry had planned on initially. The growth response is measured at 6 and then again 12 months until they're done with the growth hormone. So usually it's a sub-Q injection given 6 to 7 days a week. Some physicians feel the kids should have a day off of the hormones, so they give larger doses for 6 days, and others feel like it's better to give smaller doses because it's more consistent. Child gets used to it, and the growth is consistent. The child will be on the injections until bone maturation takes place. So generally for boys it's 16 and girls it's 14. It won't be stopped after a year, whether they see progress or not. They need to wait. Around when the child's an adult and they've stopped at, let's say it's 16 if it's a boy, they actually will redetermine if the child needs more treatment or not. Because boys can grow usually to 21 or so. So if they stop it at 16, around 18 to 20, they'll redraw blood work and see if the child would benefit for some more growth hormones. So the nurse, when she sees the child, will plot the height and weight on a growth chart and usually watch for the decline. We hope always for an incline, but we really are worried about if it starts declining. All tests need to be explained to the families, and then it's the nurse's job to monitor the child. The child may have been bullied because he's smaller. The parents might treat him like a baby even though he's older. So they need the nurse's help to treat this child as his age identifies him, and to give him all the support. Children are afraid of shots, and parents may call and say he's throwing a fit, and the nurse just needs to be prepared to be supportive of the family during this time. The family needs to see the endocrinologist approximately every 3 to 4 months, and they may need a reminder for this. And the drugs that are used, usually it's somatropin, but on page 392 of your book, there's some really detailed information on your drugs and on the side effects of the medication. So in type 1 diabetes, it's the destruction of the pancreatic beta cells, which is what produces the insulin. So nothing's producing insulin for these children. There's several causes for it. It can be genetic and it can be inherited. It's thought to be an autoimmune disease. And interesting enough, that autoimmune disease is always attacking something. And it says that the system mistakes insulin cells for invaders and attacks them. It can be environment. It can be toxins that the child has been exposed to in the environment, or a virus. But it also could be that a genetic makeup predisposes the child to allow a virus or some chemicals to attack their islet cell. So symptoms of the child, we usually see them around 2 years old for a little while. Then between 4 and 6, usually the kindergarten checkups actually catch a lot of these children. And then it peaks between 10 and 14. That's when most of the children are diagnosed. The symptoms are similar to adults, and in fact, they're probably the same. The polyuria, the polydipsia, and the polyphasia. Children will complain of nausea, sometimes vomiting, but really they complain about abdominal pain, stomach aches. We'll put them on the scale, might be their checkup or whatever, and they'll lose weight. And that'll be like one of our first clues. And then the second clue will be how the parents describe the child as wanting to drink all the time and running to the bathroom, and the irritability. Irritability seems to be the number one issue on the younger children. They're very crabby. They don't really complain about blurred vision, but if you ask them, and they're old enough to understand it, they may tell you. The younger children don't quite understand blurred vision. Of course, at that point, when they have all these symptoms, they probably are dehydrated because their blood sugar is probably very high. And we know that they are susceptible to infections. Checking their blood and urine will see that they have a high glucose in their system. So at the moment, a random blood test is one that's just done without fasting, done, whenever. And if the blood glucose is above 200, we suspect diabetes, and we send them for a fasting glucose. If it's the fasting glucose is greater than 126, they're very suspicious of having diabetes. Urine can be dipped, and it could show glycosuria and sometimes ketones if their blood sugar is very high. The glucose tolerance test, the child needs to consume a pretty balanced diet for about 3 days, and then they fast for 8 hours except for water, and then a baseline blood work is drawn, and then they're given some glucose to drink according to their weight, and their blood work is drawn every 30 minutes for 2 hours. They need to be observed for hypoglycemia throughout the whole procedure. Glycosylated hemoglobin, or an HbA1c, will be done initially, and then it's done about every 3 to 4 months or so. This will tell us, once the child's diagnosed, is how well he's managed, according to what number he gets. So normal in general is 4 to 6. But for a child, we'll allow it to go to 6.5 to 8. But we really would like it under 7. It's ideal to be under 7. But with a child, we would tell them that they're doing fine. The child will the first thing that they will learn to do is self-monitor blood glucose using a glucose meter or glucometer. So for their test, fasting glucose means no food, only water, 8 hours prior to the test. For the oral glucose tolerance test, I've already gone over this. They need to have balanced diet for 3 days. Generally, if a child comes in DKA, they will need an ICU bed. Immediately, they will need IV access. They'll be hooked up to cardiac monitors. And it's important to take the time to explain to family everything that's suspected and going on. To assess them, they should be checked for ketones in the blood and urine. Blood work should be done for glucose, electrolytes, BUN, ABGs, and CBCs. And they should be assessed for dyspnea, confusion, weight loss, and DKA signs and symptoms. So this slide is kind of like an FYI slide. I took your generic names like Lispro and looked up the train name, just in case you've heard the others, you thought, oh, they're discontinuing them. But no, it's just that now we're using all generic names, and in a way it's good because it's one name for each type of insulin instead of several. This is actually taken straight out of your ATI book, and you can look in your book on page 217. So you really need to know the difference between the rapid acting, short acting, intermediate acting, and the long acting insulins, what each one is, the onset, peak, and duration. It's very important that you have a good grip on this. Insulin administration, you probably learned your fundamental times. But for injections, there are some children will only receive 2 injections, one in the morning and one at night, and some will receive several according to their blood glucose. Mixing is usually the rapid, and then draw up the intermediate insulin. And I have a picture of a regular insulin needle there, and then I also have the autolet or the auto injector insulin where it's programmed to how much the child gets, how many units, and the child can do it themselves. They actually can do the other one themselves, but this one's easier. And then the pump. It delivers regular insulin that is pre-programmed on a consistent basis. But if the blood sugars go up and down, depending on, what's been ingested or exercise, boluses can be administered. It's usually before meals, if they're a little bit high before meals. And on the top left corner, I have the injection sites. When we teach little kids how to inject their insulin, we tend to use the tummy, first of all, so that they don't become afraid to use their tummy, but second of all, because they can really see what they're doing. So medication and teaching about the medication. The first thing is always teach never to mix glargine with any other insulin. The second is to talk about the rotating sites after 4 to 5 days. There's a couple of reasons we've always emphasized the diabetics need to rotate their sites rather just always use in one place that works well for them. Injecting into the same spot can cause a buildup of fat under the skin. It's called lipohypertrophy, and it can slow the absorption of the insulin. Or it could cause a wasting of fat under the skin, which does not look good, and that's lipotrophy. The best places to inject insulin are the upper arms, the thighs, the buttocks, and the abdomen. And the abdomen's at least 2 inches away from the navel. Because the rates of absorption really vary considerably from one body region to another, it's currently recommended rotating injection sites within body regions rather than rotating to a different region with each injection. So what that means is instead of going right leg, right arm, left arm, abdomen, and maybe hip, is to go right leg, but go like uphill, 1, 2, 3, 4, 5 for sites. Insulin is absorbed fastest from the abdomen, followed by the arms, the thighs, and the buttocks. So it is suggested that when a parent is helping a child and they're choosing their injection sites, to kind of keep an eye on what their blood glucose level does for each side, so they can actually explain in their records, well, we move to the leg, and whenever we use the leg, especially if it's an appendage that the child uses a lot, like if he's playing tennis, it would be his arms, it's going to change how the insulin's absorbed. So that person can, record every time we use the right leg, we get higher glucose readings. Therefore, we have to decrease our glucose amounts or whatever, just to make it clear. If it's the shot, the child's doing a sub-Q shot, it's still given at 90 degrees, that you need to pinch up the skin, and no longer are we checking for a blood return. And I don't know if you guys were even taught that. I think it's been several years. Always draw up the shorter acting insulin first when it needs to be mixed. As a nurse, you're going to observe both the child and the adult first in drawing up and then administering the insulin. You're going to also, if the child is going to use a pump, both the parent and child have to be able to make the pump adhere to the child. You're going to observe both members for their self-monitoring blood glucose levels and how they record it. And then the next step is, it's really ideal to have handouts or go yourself and educate teachers and the school nurse, the guidance counselor. Coaches is a big one. And if the child goes to daycare or has a babysitter, they all need to know how to take care of this child. So the child's admitted, you're in ICU, you're going to do their vital signs and their glucose levels. They're going to be on accurate INO and daily weights. You're going to start monitoring what their skin looks like, their feet, the skin everywhere, and any wounds that may be healing. You're going to observe for sensory and visual alterations and infections. So if they start saying, my feet are burning, I don't feel my feet, or I'm having trouble, I see double, that needs to be documented. At first, when they get their trays and they're allowed to eat, you really want to be accurate and note their dietary practices and exercise patterns. And this is something you can even ask them, what do you normally eat? Tell me, do a diet recall for me, or ask the parents. The same with exercise. So are you on any sports after school? Are you into dance club? You need to know all this, because that's going to determine your discharge teaching. You're going to also be sure to determine the child's proficiency at self-monitoring and giving their own insulin. If the child's very young, we'll start them off first with recording. Then we'll have them do their blood glucose meter. And then last will be the administration. You're going to educate the family on the nail and wound care. Some doctors will allow the families to go ahead and keep the nails short and take good care of them. And other places, other doctors will want them to see a podiatrist. You'll also have to discuss to them that they need to file the child's nails straight across, and really warn them about the child walking barefoot or wearing sandals or wearing shoes without socks. We want to keep and preserve those little feet as long as we have some control over it. Hygiene is very important, and these kids might get a little depressed because this is a big change in their life. And one of the signs that we see with depression in children is they really don't want to take care of themselves and bathe and have good hygiene. But we also need to teach them that it's important to care themselves just so that they don't get an infection. All children should get a medical bracelet, and some people even will leave a second one, like in the car seat, on the car seat for the child or the stroller. You have to really stress the importance to the family of seeing an eye doctor, going for regular health checkups, seeing the dentist regularly, and of course their endocrine follow-up. Nutrition for them is very, very important. And your ATI book on 216 actually has a nice paragraph talking about nutrition. So it's important that the kids learn not to skip meals, that they need to eat at regular times, and they need to learn to be able to count carbohydrates. So generally the family starts first, the parents, but they start teaching the child. It's very, very important. They need to learn to avoid high fat and high carbohydrate food items and to enjoy other foods. And you know, the verdict on the artificial sweeteners is still out, so they can use them, but in moderation. We're not sure. Some people feel that it does raise the child's blood glucose level. If the child is going to be on some kind of after school sports, or if they're in sports, or you know, when they have PE, they require a snack about 30 minutes prior to this activity. And generally, it's 15 grams of carbohydrates that's given to them. So it could be 4 ounces of orange juice, or some places actually encourage the kids to do 8 ounces of milk. They could do 3 to 4 glucose tablets, or 4 ounces of a regular soft drink, which is the teenagers kind of like that generally. So that's 15 grams. It's 10 to 15 grams that they need before they. Other parents will do some graham crackers with a little bit of peanut butter on it, or an apple and peanut butter. The parents need to be taught the illness management. If a child gets sick, they still need to receive their insulin, and that's probably the biggest mistakes parents give. The child's vomiting, they're not going to eat, and they'll not give their insulin. So on one of the next slides, I have the illness management guide. They need to know the signs of hypoglycemia and the treatment for hypoglycemia. They also need to know the signs of hyperglycemia and the treatment. They need to, when the child gets sick, they need to monitor their blood glucose every 3 to 4 hours while they're sick. The child needs to get their insulin. They need to drink, so 4 ounces of sugar-free liquids every 30 minutes to prevent dehydration. They need to take in a little bit of carbs. As long as someone's checking their glucose and they got their insulin, you know, they could have some graham crackers or something, or some saltines if they're sick. Their urine needs to be checked for ketones. They need to know when to call the healthcare provider, and that is if their glucose is above 250, that should be milliliters per dilute. Or if they have a fever that doesn't respond to acetaminophen, or their fever comes and goes for 12 hours. If they vomit more than once, or diarrhea more than 5 times, or it lasts more than 24 hours. If the child becomes disoriented, has rapid breathing, or if they cannot keep oral fluids down for 2 days. So with hypoglycemia, the symptoms are on the left, and the lab values are on the right. So the parents need to be taught the signs of hypoglycemia. The treatment for it is listed here. It's also in your book, and it's in your ATI. So in general, you really want to know the reason the child is hypoglycemic. You want to see if it's that they, you know, now are maybe taking 2 gym classes and they're not having a snack before, or if they maybe they're growing, and during a growth period the child may become a little bit hypoglycemic. Here is the general rule of thumb to how to treat hypoglycemic reactions. So the onset of DKA in a child is very rapid, and their blood sugar will be above 330 for them to be considered DKA. Everything happens quickly, and they need to be, as I mentioned before, on a monitor. And we need to start getting labs, and we need to move quickly so that they don't go into a coma. Frequently, these children will have a history of fatigue, malaise, nausea, vomiting, abdominal pain, and thirst and frequent urination. Until we actually get the lab results back, it'll be tough to see, but the treatment goals will be the management of the dehydration and any electrolyte abnormalities. We'll also look to take care of their acid-base abnormalities. So they'll be put on a cardiac monitor to watch for dysrhythmias. We'll get our IV access going. We will probably keep an MPO during this particular time, and many times they'll put a Foley in to assess the urine output. When the blood cancers are done, we'll kind of watch for acidosis, which probably is going to happen, but depending on how severe it is, tells us how much bicarb will need to be given. This is a child that came to the ER with a blood sugar above 330 milligrams per dilute. And so we'll put them on their cardiac monitors, as we mentioned. We'll get IV access for them. And most of the time, we'll actually put a Foley in too, so we can have accurate INO. The IV fluids that will be started is 0.9 normal saline, and it'll be started quickly, like 1.5 times maintenance, to reverse that dehydration and get perfusion to all the organs. At the same time, we'll want them on INO so we don't overload them. Blood work will be drawn constantly, so we'll monitor the blood glucose, and when it reaches 250 milligrams per dilute, we'll start either D5.9, which is the most common, but sometimes they do order D5.45. And we do that in order to maintain that blood glucose at 120 to 240 per dilute. The blood glucose now, as we correct the dehydration, will be dropping rapidly. We'll add a regular insulin drip at 1 unit per kilogram per hour, and we'll continue to monitor that blood glucose hourly. Children with DKA have a potassium regulation problem. So most often these kids have a total body potassium deficiency. Although when they first come in, it may appear to be normal or even high when it's the blood work's drawn and you get the results back. The reason this happens is because the serum acids compete with the potassium ions and push them from inside the cell to outside the cell where they're measured. So we're measuring a very highly concentrated blood with potassium, although there's none in the cells. When we begin to correct the acidosis in a little bit, the potassium will get back into the cells, and the serum potassium levels can really fall to a dangerous level. So we'll constantly measure our blood glucose hourly as well as our other labs. We'll monitor that KCL, and at this point, if it's dropping low, and we know the child's voided because he hasn't Foley in, we'll go ahead and add some potassium chloride to the IV as well. If the pH is less than 7 and it's severe acidosis, we'll be giving some sodium bicarb, and we'll do it slowly over a certain amount of time, whatever's ordered IV infusion, but we have to watch the potassium carefully. We don't want it to drop lower. If the child seems to have low SATs and having decreased oxygen level, they can have oxygen therapy, and once again, we'll monitor that with their blood gases. Someone should constantly monitor for level of consciousness. And unfortunately, the complications for DKA is severe renal disease, vision disease or problems, and definitely neural problems. Once again, here's some signs. This is a great little thing that could be put on a folder to give to the families on what to watch for at home. So we're going to leave our type 1 diabetic, and I really, really want you to read that carefully in your textbook. Your textbook really does a halfway decent job with it. I'm not going to rewrite the whole book on a PowerPoint for you. I just gave you the Reader Digest version of it. The type 2 child diabetic, usually we find that their body is not using the insulin that's produced properly. And we find that, that this is going on. It's a chronic condition, and it's how the body metabolizes glucose. The children usually have a high BMI. They're usually very obese. And so when we have an obese child, more than 85% for their weight on their growth chart, we should suspect type 2 diabetes. If not, the child will first have obesity, and not only will we be working with type 2 diabetes, but we'll also be working with hypertension and high cholesterol levels. Children with type 2 diabetes generally don't state that they have any symptoms at all. Sometimes, though, we'll hear that they have the tingling and burning of their feet and ankles and legs. Sometimes they complain of blurred vision. They're usually very fatigued, and we'll hear that from the families. And many of them will have acanthosis nigricans, which is that brown mark that can be around their neck or under their arms, sometimes on their hands. And that's a typical sign of insulin resistance. So with type 2, we'll do, a fasting blood sugar, and generally it'll be over 125. We will do a random glucose, which usually will be over 200. And their A1C will be usually greater than 7. Many times the physician will order an oral glucose tolerance test. The nursing care for the child with type 2 diabetes is, number one, we need to assess them for risks such as obesity, hypertension, renal disease. We need to, start looking for these symptoms with them. We need to get a great dietary history, usually a daily dietary diary is good, and we need to refer them to a dietitian. They need to be encouraged to exercise or be active. If you use the word exercise, they might not like it, and physical therapy can generally help with that. A lot of times they're put on oral anti-hyperglycemic medications like metformin, or I think the other name is Glucophage. And unfortunately, these kids are also bullied a lot and picked on a lot, even from their own family. So we have to assess them for psychosocial needs. One of the things to get through to this is when you look at the child who might be obese, so may the family. So it's sometimes difficult to convince them that this child needs help. We need to teach them the importance of exercise. We also need to teach them dietary management. They have to learn with the child how to check the child's glucose. If the child is given medication, it's important to explain how to give it, what the side effects are, and the frequent follow-up they may need. Every now and then a child will need insulin if they're severely uncomfortable. Talk about genetics. And the first one is PKU. This is, and I wrote it this way because I wanted you to start getting used to seeing it's a single gene genetic disorder with an autosomal recessive inheritance pattern. And what it is, it's the inability of the body to use essential amino acids because there's been a mutation in their gene. In the United States, just as the thyroid, the T3, T4, TSH, is screened with the newborn, so is the PKU. The child definitely needs to be 24 hours old or it will be inaccurate. In fact, this is the one that actually comes back inaccurate a lot and needs to be redrawn because it's done too early. I found this great little kind of definition or explanation of it. It's rare, it's genetic, and it causes the protein to build up in the body, the amino acids. And phenylalanine is found in all proteins and also in some artificial sweeteners. So we don't know if it's because mom maybe had some NutraSweet or something during her pregnancy. We don't know. So I wrote it again. I can't believe I wrote it twice. But if it's not treated in a few months, within the few months of life, the child will start having really bad neural signs like the seizures and the tremors and bad skin condition. They will be hyperactive. They won't grow. The musty odor of their breath, skin, and urine is if this is left a couple months. Unfortunately, it will be led to irreversible brain damage and cognitive issues. Some children will have a behavior problem. So once the child, we find out that they are positive for PKU, they need to be instructed on a special diet that limits the foods with all these proteins in it. The child can be breastfed. That was a question for a long time. In fact, this has just been known recently that it's okay that they breastfed. But they cannot have any regular formula that has protein in it. So there's a special formula that I have listed here, Alofenlac, and it comes actually from the government, and all the parents have to do is apply for this and have a positive PKU test to show them, and they will receive this for the rest of the child's life. Because even when the child gets bigger and is eating foods, he will need to use this formula. As the child grows and starts eating regular foods, they need to be taught, as well as the parents, no foods high in protein. And here is the list: the milk, the eggs, the beef, the nuts. The child cannot have any of these. Okay, chromosome anomalies or abnormalities. And what I did is I kind of just wanted to give you an introduction to it. This is in a genetic class. We could go into this, and it's pretty interesting. I just wanted you to know, exactly how our normal chromosomes, a set of 46, and we get half from our mom, the other half from the father. And the first 22 pairs are called autosomes. So when I say it's an autosomal trait, it's from the first 22 pairs of chromosomes. The final pairs are sex chromosomes, our X's and our Y's. And we know that the mother and father each contribute one set of the 22 autosomes and one sex chromosome. So there's a lot of different types of chromosome abnormalities, but actually I looked at your ATI to see what they wanted you to know. And these are pretty good. Some of these you'll hear again and again. The trisomy, for instance, there's an extra set of chromosomes. The monosomy, which makes sense, there's one missing. The duplication, part of one of the chromosomes is duplicated, so there's more than one. It goes down the list, inversion. Please kind of get familiar with these different types of chromosomes, so that if I say, what does it mean when it says somebody has a trisomy? You would be able to say, well, it means they have an extra set of chromosomes. They have an extra chromosome. The risk factor for a chromosome abnormality can be a parent that has an existing genetic disorder themselves or an error of metabolism, or it can be a close relative. It could be that this family already has one child with a genetic disorder, so that puts them at risk for having another one. A family that has stillborn children are at risk for genetic disorders. Parents who are closely related. That's one of the reasons that it's illegal to marry your cousin or your brother or whatever. Unfortunately, women older than 35 years or men older than 55 years at the time of conception is a huge risk factor. When we know that it used to be 40 for women, and they found that many women between 35 and 40 have kids with chromosome problems. And any exposure to environmental toxins, the cytomegalovirus, radiation, or chemicals. And the toxin, we recently had a virus going around that could actually affect the child's chromosomes. So I also wanted to talk to you a little bit about what these different chromosome terms mean. And I found by just looking in your ETI, I actually had a lot more. So this was a nice way to stop it. But the common disease that's associated with the modes of inheritance. So when one parent gives an abnormal gene, it's called an autosomal dominant. And we see it in Huntington's disease and Marfan syndrome. These are really cool. If you have time to look some of these up, they're very interesting, and they kind of sneak up on us. All of a sudden a baby's born with this. For the autosomal recessive, like our cystic fibrosis kids, there's 2 copies of an abnormal gene. It can be 2 traits. It can be a trait and an actual diagnosis, but it has to be 2, one from each parent. So we see this in CF, we see this in the PKU, and galactosemia. That is when the babies are born, their urine smells like sugar, and they get that kind of a diagnosis. The Tay-Sachs. So that's it. Please read your book. It's very, very important that you read over all of these defects so that you can answer questions about them a little bit more thoroughly. Just read the things that we have on the slide. You don't have to read the whole chapter. You might want to someday. They're pretty interesting. But at this point, please read them over. There will be questions from your book. And I hope to see you in class.